Okay, good morning. It's a great pleasure to be back here in Bethlehem with many of my friends. We do this on an annual basis, and I hope that we will continue to do this on an annual basis. So I think Mohammed gave you a fantastic talk about what patients need insulin and don't need insulin. I just want to emphasize that if you're going to treat patients who don't need insulin, you need to use the right medication. And clearly, you could see from what Mohammed took you through, the right medication is a GLP-1 receptor agonist plus pioglitazone. And I know that people have lots of misconceptions about pioglitazone, and that prevents us from using this drug in general practice. And today, what I'm going to try to do is take you through some of those misconceptions and show you that, in fact, the pioglitazone can very effectively be used. I might also say that I know the airlines tried very hard to make sure I didn't get here last night, but after 36 hours, I actually did make it here. So again, it's a great pleasure for me to be here. So let's start. I think everybody is familiar with this slide, the ominous octet. It's from my Banting lecture in 2008. And there we go. And the purpose of the ominous octet is to emphasize that if you're taking care of people with type 2 diabetes, there are multiple pathophysiologic abnormalities. And I'll take you through them briefly. But what you need to understand, therefore, is that no one single drug is going to correct all of these abnormalities. And as Mohammed took you through, he pointed out the two drugs that he used in those studies, exenatide. I'm going to maybe talk about that a little bit later. But the GLP-1 receptor agonists correct 8 of the problems in this ominous octet. And the other drug that he used in the Qatar and in the EDIC study was pioglitazone, which corrects 4 of the problems. So just for brief review, we know that the 3 major abnormalities that are present in people with type 2 diabetes are insulin resistance in the liver, lower left. You go to sleep at night, your liver produces too much glucose, this is fasting hyperglycemia. And the bottom right, insulin resistance in the muscle. You wake up in the morning, you eat a meal, the carbohydrate's supposed to be taken up in the muscle, muscles resist the insulin, postprandial hyperglycemia, and then in the upper left, beta cell. With time, your beta cells start to fail, and Mohammed took you through that natural history of that very nicely. But there are 5 other problems that we have to deal with. Upper right is the fat cell. When you overeat and take in excess calories, they're stored in the fat cell. As long as the calories stay there, they can't hurt you. But the problem is, as your fat cells expand, fat cell becomes resistant to insulin, and then now you start to break down the triglycerides. You release FFA into the bloodstream. Elevated FFA causes insulin resistance in muscle and liver and impair beta cell function. At the top, at 12 o'clock, is the gastrointestinal tract. So when you ingest a meal, you release 2 incretin hormones, GLP-1 and GIP, and those 2 incretin hormones account for 70% of the insulin that comes out in response to the meal. And what we have learned is that your beta cells are resistant to both GLP-1 and GIP, and then we have a treatment. Mohammed took you through exenatide. We actually have many GLP-1 receptor agonists, and we just give a pharmacologic dose of the GLP-1, and we overcome the resistance. We also know that the gastrointestinal tract, in addition to playing an important role, has a bunch of other problems that go with it. And one of the problems is shown down in the bottom, that's the brain. So you release GLP-1, and GLP-1 sends a signal to your brain to stop eating. It turns out that your brain is also resistant to GLP-1. You overeat, when you gain weight, you become resistant to insulin. At 9 o'clock is the alpha cell. The alpha cell hypersecretes glucagon, and glucagon drives hepatic glucose production throughout the sleeping hours, and that contributes to fasting hyperglycemia. And then at 3 o'clock, we have the kidney. The threshold for you and I, at which when the glucose goes up, we start to dump glucose in the urine, is about 180. But in people with type 2 diabetes, that threshold goes up. So you can see that this is a complicated disease. And I could add a couple of more pathophysiologic abnormalities, which I'm not going to do. But the point is, you're going to need multiple drugs in combination. And if you're using drugs that correct multiple of these defects, as Mohammed took you through, as do the GLP-1 receptor agonist and pioglitazone, you're going to more likely to have a successful endpoint. So we need multiple drugs. And again, Mohammed pointed this out, and he and I agree very strongly on this. You shouldn't simply be using drugs that lower the glucose, that don't correct the underlying pathophysiology. So sulfonylureas really don't do anything on a long-term basis. Major effect of metformin is on the liver. It corrects one of those problems, but it leaves 7 uncorrected. And then we need to start early before we start to lose beta cell mass. So what does not work, okay? So Mohammed showed you this slide. This is United Kingdom prospective diabetes study. Dr. Robert Turner really believed if you took newly diagnosed type 2 diabetic patients, started with an A1C of 7, and you put them on a single oral agent, and the 2 agents that he used were glibenclamide, a sulfonylurea, metformin, he believed the A1C would come down and stay down. So there were, in this study, about 4,500 individuals divided into 3 groups, diet and exercise. You can see a progressive rise in A1C in the conventional diet group. This was all due to beta cell failure. Again, Mohammed showed you this slide earlier. You can see whether you treat with a sulfonylurea metformin, after initial response, this progressive beta cell failure, and these abnormalities or this natural history was reproduced in the recent GRADE study. Now, that separation of 1% did decrease eye, kidney, and nerve complications by 37%, and that's why everybody cites the UK PDS, but it also told us what drugs are not going to work. And so what are the 2 most commonly prescribed drugs in the United States? Metformin, sulfonylureas. In the world, metformin, sulfonylureas. So why do we use those drugs? Well, primarily because they're inexpensive. The newer drugs are more expensive. If people could afford the newer drugs, hopefully after we finish between Mohammed's talk and my talks, you'll see you shouldn't be using these older drugs, okay? Now, I brought metformin to the United States in 1995. I like metformin. It's a good drug, but we clearly have better drugs. Now, here are the data. There are 8 long-term studies with the thiazolidine diones, rosiglitazone and pioglitazone. You see a very, very different picture here. The initial decline in A1C is different because the study designs are very, very different. But whatever that initial decline in A1C is, you can see A1C stays down. Now, if the A1C comes down and stays down, that can only happen because the drug has an effect on the beta cell. So you can't measure beta cell function as Mohammed and I have done over the years, but you all can measure the A1C. And if the A1C is rising, it's telling you that the drug you have the patient on is not affecting the beta cell, okay? Very simple measure of beta cell function. A1C rising, beta cells failing. And so you all think that TZDs are insulin sensitizing drugs, and of course they are. So over the years, Mohammed and I and other people in the group have used the insulin clamp to measure insulin sensitivity. So we're just going to infuse insulin, and then with radioisotopic glucose, we can measure the rates of insulin-mediated glucose metabolism. And I just want you to focus on the height of the bars. So before starting the pioglitazone or the rosiglitazone, that's the yellow bar. Then what happened after 6 months of pioglitazone or 6 months of rosiglitazone, you see about a 35 to 40% improvement in insulin sensitivity. But the real reason the TZDs work is because they have a powerful effect on the beta cell. So the disposition index is on the y-axis here. So this is the increase in insulin secretory rate during the OGT, factored by the rise in glucose during the OGT, all factored by how insulin resistant you are during the insulin clamp. Drug-naive patients were in this study, And you can see the placebo had no effect on beta cell function. If you look at the pioglitazone curve, that's the green curve, I triple your beta cell function. If you look at rosiglitazone, a 2.5-fold increase in beta cell function. So TZDs are very, very important because they're insulin sensitizing drugs, and they also work on your beta cell. So if we come back to the ominous octet, and in my opinion, this is where the guidelines that the American Diabetes Association puts forward are wrong, because they put the focus on the A1C. Now, what you really should be doing is correct the pathophysiology. If you do that, the A1C will come down. And so what the TZDs do, they're good insulin sensitizers in the liver, good insulin sensitizers in the muscle, good insulin sensitizers in the fat cell, and very good at improving beta cell function. So they correct 4 of the problems that are present in the ominous octet. Now, our diabetic patients are at very, very high risk for cardiovascular disease. So what have we learned about TZDs in cardiovascular disease? So the very, very first study carried out was the proactive study. It was carried out in Europe, 19 countries, 5,238 patients. To get into this study, you had to have a previous cardiovascular event. Could be a heart attack, stroke, etc. And then you're randomized to either pioglitazone or placebo. And you can see in the left, the hazard ratio is 0.84, and the MACE endpoint, which stands for Major Adverse Cardiovascular Events, and there are 3 of them, non-fatal MI, non-fatal stroke, cardiovascular mortality, was decreased by 16%, and this is highly statistically significant. Unfortunately, this was the secondary endpoint. The primary endpoint was MACE plus peripheral vascular disease, and we learned from this study that peripheral vascular disease doesn't respond to any drugs. And so, unfortunately, with the TZDs, we had to learn this lesson. FDA only approves drugs if the primary endpoint is significant. So pioglitazone did not get a formal approval in the US. Now, concurrently, in the US, Takeda Pharmaceuticals was carrying out a number of studies to get pioglitazone approved. And so to get into these studies, you could not have a previous cardiovascular event. So you could be drug naive, I had pioglitazone. You could be on metformin, I had pioglitazone. SU, I had pioglitazone. The FDA then did a meta-analysis. This is FDA, not Takeda. This slide is taken from the FDA website, okay? They did a meta-analysis of all the Takeda studies carried out in the US to get the drug approved. Hazard ratio is 0.75. This is now primary prevention on the right. On the left is secondary prevention. So we have lots of data that TZDs, and particularly pioglitazone, protects you against cardiovascular disease. Now, in the proactive study, if you had a stroke, recurrent stroke was decreased by 47%. Recurrent MI was decreased by 28%. But you can see this enormous reduction in stroke. The best treatment in the world for stroke. So Silvio Inzucci and Dr. Kernan, who's a neurologist, went to the NIH and said, we should do an intervention study in people who've had a stroke. So to get into this study, you could, number one, not be diabetic. Mean A1C in this study is 5.8. That means many of these people, half of them had normal glucose tolerance. The other half had just impaired glucose tolerance. No diabetes, and you had to be insulin resistant. And then they followed these people up, you can see here, for 5 years, and they then asked, okay, can pioglitazone in a non-diabetic population prevent recurrent stroke in cardiovascular events? Hazard ratio is 0.76. There was a dramatic reduction in cardiovascular events in recurrent stroke. And I guarantee you, there is no better treatment that you people out here can use in your patients who have had a stroke than pioglitazone. And unfortunately, most people are not aware of this study. So Muhammad and I asked Dr. Inzucci, could you go back and do an analysis, a breakdown, based on the dose of pioglitazone? So the hazard ratio for stroke and MI is shown on the left, and the hazard ratio for new onset diabetes is shown on the right. Because remember, none of the people in this study had diabetes at the time of the study. And then we broke it down into the entire group. So the hazard ratio for the entire group was about 0.7. That's the orange bar. And then how did this relate to the dose that the patients were on? The 15 milligram or the 30 milligram or the 45 milligram dose. And you see, it didn't make any difference what dose of pioglitazone you were on, you still got benefit. So we really push up to the 45 milligram dose in practice. Now, when Muhammad and I did many of the studies, we did, just to be on the safe side, go to the 45 milligram. But in primary care of our patients, we usually start at 15 and go to 30, but not above that. And then at the right, we looked at the hazard ratio for new onset diabetes, 80% reduction in new onset diabetes, okay? So what about structural abnormalities? There are actually a lot of data showing that pioglitazone can prevent structural atherosclerotic abnormalities. So these are data from the Chicago study by Dr. Mazzone.
2 minutes,
which,
2 minutes, please.
I'm going to speak more.
2 minutes.
Yeah, I'm going to overspeak. Sorry, I didn't know how long I was given to talk. So I prepared the talk. It's going to be a little bit longer.
Okay.
Yeah, so I only get to come here once a year, and it was 30 hours. So I think I get an extra minute or two. All right. So you can see if we look at carotid intimal medial thickness in people treated with a sulfonylurea glimepiride versus pioglitazone, you progress with glimepiride, no progression with pioglitazone. And in the right, this is Dr. Stephen Nissen's study looking at coronary atherosclerosis using IVUS. And you actually can see progression with the glimepiride and regression with the pioglitazone. So we have real data, you just don't die and have strokes, and we can show you that there's regression of the lesions. So how does this work? So PPAR gamma activation directly is anti-atherogenic. We improve insulin resistance in the multiple components of the insulin resistance syndrome. We increase nitric oxide, which is a potent anti-atherogenic molecule. We decrease inflammation. We reverse lipotoxicity. We lower the blood pressure, and we correct diabetic dyslipidemia. So there are many, many reasons why pioglitazone works. And we also carried out in San Antonio a primary prevention study in people who had prediabetes. Now, there were 4 studies in the literature, tripod study with troglitazone, bipod with pioglitazone, the DREAM study with rosiglitazone, and the ACT NOW with pioglitazone. So we screened 1,850 people. We found 600 people with IGT. They divided into placebo or pioglitazone, and then they were randomized. And you can see here, 7.6% conversion rate per year versus 2% conversion rate per year with the pioglitazone. Hazard ratio is 0.28, a 72% reduction in the blocking the conversion of prediabetes to diabetes. And the number needed to treat is 18. This is an incredibly low number. You have to treat 18 people with IGT for 1 year to prevent 1 case of diabetes. Now, what about TZDs and steatohepatitis? So NASH and NAFLD are a big problem that's now recognized in our diabetic patients. And I would argue that the best drug that we have, and I think it's going to be very difficult to beat, pioglitazone. So this is the original study that Ken Kuzi, Dr. Belford, and I carried out. It was 55 people with type 2 diabetes. They had elevated AST, ALT. They had biopsy-proven NASH and NAFLD, and they were randomized to a low-calorie diet, 500 plus placebo, or the low-calorie diet plus pioglitazone, and then we followed them up. And you can see here over the first 6 months, dramatic reduction in AST and ALT in the pioglitazone group. The placebo group also lost weight because they were a low-calorie diet. Some benefit in yellow, but not nearly the benefit you see in orange. And now you look at inflammation, left ballooning necrosis, next steatosis, fibrosis, dramatic reductions. We expanded this study to about 155 people, followed them for 2 years, and showed that these benefits all persisted. Now, side effects: weight gain, bladder cancer, fluid retention, bone fractures. Well, what about the weight gain? So this is, when I give a talk, the slide that most people ask me about. This is the fat man slide. If you look at people who have diabetes, they have fat everywhere. The plasma FFA is elevated, but you never measure it, okay? Fat in the muscle, fat in the liver, fat in the visceral cavity, fat, importantly, in the arteries, and then fat in your beta cell. And when I put you on the pioglitazone, and I'm not going to go through exactly how this happens, but you redistribute the fat. So you can see fat in the liver goes down. Best drug for treating NASH, in my opinion. Fat in the visceral area goes down. Fat in the muscle goes down, dramatic improvement in insulin sensitivity. Fat in the bloodstream goes down, and importantly, fat in the arteries. This is why you get the protection against atherosclerosis. Fat in the beta cell also goes down. So now, I love to give this talk to cardiologists. So what in proactive is the only factor that predicted you're not going to die? And you know, if there are 100 cardiologists in the audience, there are 100 wrong responses. And I love it. There's only one factor that predicts you're not going to die: weight gain. So you have a choice. You can either be fat and alive or lean and dead. Who votes for being fat and alive? I vote for this one. Who wants to be lean and dead? Oh, one hand. No, she took her hand back down. So a little bit of weight gain, maybe not so bad, okay? Now, this now is an analysis that was, this is a study that FDA made Takeda do in terms of bladder cancer. Big study, 193,000 people, 1,089 developed bladder cancer. What was the hazard ratio in the people placed on pioglitazone versus placebo? 0.98. That's as close to 1 as you can get. No increased incidence in bladder cancer. Now, pioglitazone and myocardial function, these are studies that we carried out. Mohammed and I were involved in these studies. They actually are published. I'm going to read from you left to right. These are diabetic patients. A1C, okay, dropped from 6.7 to 5.6. No surprise. During the insulin clamp, a major improvement, 3.4 to 5 point, almost double your insulin sensitivity. We did this with fluorodeoxyglucose, looking at myocardial insulin sensitivity. Major improvement in muscle insulin sensitivity in the heart, and then myocardial blood flow to the right, big increase. And then if we look at the ejection fraction, it improved. So all you people who think that pioglitazone is doing something wrong to the heart, you're wrong. And this paper's been published for a long time. And if I were to ask 100 cardiologists, maybe 5 would be aware of this paper. They have in their mind that pioglitazone does something bad. And then measures of diastolic dysfunction, E over A, et cetera, peak flow rate in the left ventricle, all benefit. So in conclusion, pioglitazone causes a very durable reduction in A1C, and it persists, we know, for at least 5 years, and improves insulin sensitivity and beta cell function. I didn't take you through the insulin signaling data. We know exactly how it works by improving the insulin signal transduction system. It's anti-inflammatory. It reverses lipotoxicity. It has cardiovascular protective effects, and it protects you against NASH and NAFL. So in my opinion, in all of your patients, you should consider pioglitazone as first-line therapy. Contrary to a lot of the misconceptions that are out there, I hope I've dispelled many of them. And if you will use the pioglitazone with exenatide, as Mohammed and I have done over the years, you can see the incredible benefit that Mohammed showed you, and I'll show you a little bit more later. Thank you very much for your attention.
Thank you, Professor Ralph. Can we have 1 or 2 questions for Professor Ralph?
Thank you for the lecture. Could we use the pioglitazone for patients without diabetes, for NASH as example?
So the question is, can we use pioglitazone in people with NASH who do not have diabetes? And the answer to that, in my opinion, is yes. We know that I showed you the data that it prevents cardiovascular disease in non-diabetics, but there are also data now with pioglitazone, and there are at least 2 other TZDs that I'm aware of that are being looked at by the Food and Drug Administration that also show that it works in people with NASH as well as with diabetes and NASH, as well as non-diabetes in NASH.
As we know, we used metformin and the GLP-1 for decreasing the weight sometimes. And could it decrease? I see in your picture, you showed that it decreased the fat in the body.
Yeah.
Could we use it also for that?
So pioglitazone makes you, the paradoxical part is you gain weight. Why? Because the richest density of PPAR gamma receptors in the hypothalamus. So I put you on the pioglitazone, it signals you're hungry. So you eat, you gain weight. But all of the weight goes into the subcutaneous tissue. Then all of the other effects are redistributing fat and moving it out of the body, and moving it out of the liver, out of arteries, out of your beta cells. And that's where all the benefit is coming from. So people have gotten confused that because you gain weight, that might be bad. But I just showed you, and I didn't tell you this, but the more weight you gain, the greater the improvement in insulin sensitivity, the better the improvement in beta cell function, the greater the drop in the blood pressure, the greater the drop in triglycerides. So weight gain is telling you that the drug is working. Cosmetically, all of your patients will leave you, okay? But if, as Mohammed showed you in the Qatar study and in the edict study, if I put you on a GLP-1 receptor agonist, you actually don't gain weight and you may lose a little bit of weight. So we particularly like that combination of pioglitazone with the GLP-1 receptor antagonist. Okay, I'm going to be here for a while, so even after we finish this morning, if people have questions, you can come up and bounce them off me, and I'm more than happy to answer them. Okay.
Thank you, Professor DeFronzo. Professor Muhammad, thank you. Just a few words. Thank you, our great moderators, Dr. Saha, Dr. Hussam.